Good morning. So we are going to start this session. I have Harshul and Bardhaman with me. So let us start this session. So Harshul, please start. First paper is
So I think
effect
all
of
the
trypan
best.
blue dye. Speaker is co-authors Pankaj Chaudhuri.
Dr. Archana Sirsham.
Archana, okay. Archana is here?
She's not here? Okay, how surprising it is. She's in finals and okay. So I think next we have Dr. Bharti Kashyap, who will be presenting on flex arcuate incision versus image guided arcuate incision versus
Yes,
toric
Dr. Bharti is
IOL
here.
for minus 0.75 diopter to minus 1.5 diopter cylinder. Co-authors are Dr. Nidhi, Dr. Vibhuti Kashyap and Dr. Birendra Kashyap.
अरे ये क्या सब कर दिया है इसको बड़ा कर दीजिए लार्ज कर दीजिए So good morning everyone my
Just
topic
a minute, ma'am. How much timer we have
Five.
here?
5 minutes.
Yeah, can you set? Yes.
Good morning everyone my topic is comparative evaluation of flex arcuate incision image guided manual arcuate incision and toric IOS in management of astigmatism ranging from 0.75 to minus 1.5. The purpose is to compare the visual outcome of flex arcuate incision, image-guided manual arcuate incisions, and toric IOLs for management of coexisting cataract and corneal astigmatism ranging from 0.75 to 1.5. So, estimated 40% of the general cataract population has one diopter of astigmatism, and today cataract surgery is regarded as the refractive surgery aiming pseudophakic emmetropia, which makes eliminating corneal astigmatism critical. This is a prospective comparative study of 144 eyes, single surgeon, data analyzed by SPSS version 24. Group 1 is 48 eyes, femtosecond laser assisted arcuate incisions. Group 2, 48 eyes, image guided manual arcuate incisions. Group 3, 48 eyes, toric IOL, SN6A2 to T2 to T3 model. The outcome measures were 180 days and change in uncorrected visual acuity from 7 to 180 days, difference of visual acuity at 7 days among the 3 groups, difference of visual acuity at 180 days among the 3 groups, MTF values at 5 and 10 CPD in 7 and 180 days, mesopic MTF values at 5 and 10 CPD in 7 and 180 days. These are the inclusion and exclusion criteria. The statistical analysis was by SPSS software version 24. The gender and the age distribution among the 3 groups were comparable, and it was applied to see change in visual acuity from 7 to 180 days, and it was found significant among the 3 group. And LSD table post hoc test showed that change was significantly more in flex arcuate and manual arcuate group as compared to the toric group. This is the descriptive of difference of visual acuity at 7 and 180 days, and INNOVA applied shows significance at 180 days. Post hoc test LSD table showed that significance exists at 180 days between toric and flex manual arcuate incision, and manual arcuate incision toric group was significantly better. This is the table showed ANOVA MTF values at 5 CPD for 7 and 180 days photopeak, and again 180 days was significant, and MTF values at 180 days in toric IOL group was significantly better, photopeak 5 CPD 180 days. This is the descriptive one-way analysis at 10 CPD for 7 days and 180 days photopeak, and again in 180 days this was significant, and the toric IOL group shows significantly better MTF values at 10 CPD 180 days by post hoc test. And this is the one-way analysis, mesopic condition at 5 CPD. This is the ANOVA test at 10 CPD and at 5 CPD, and it shows significance. And it in the ANOVA and in 180 days, it shows by post hoc LSD table that toric IOL group had significantly better MTF values 5 CPD at 180 days. This is the one-way analysis. This is the ANOVA again applied at 10 CPD, and it shows significance at 180 days. And post hoc test, LSD table shows the toric IOL has significantly better MTF values as compared to the first 2 groups. at 10 CPD at 180 days. So the conclusion is flax arcuate incision, image-guided arcuate incisions, and toric IOS reduced astigmatism, but the astigmatism correction was less effective in due course of time in the arcuate groups as compared to the toric IOS. The toric IOS achieved significantly better post-operative uncorrected visual acuity and contrast sensitivity as compared to the arcuate groups, both flax as well as image-guided, at 180 days post-op, resulting in significantly less number of eyes using spectacles post-operatively. Effect of toric IOS were more predictable and sustained. Undercorrection was commonly observed in flax arcuate group and in image-guided manual arcuate groups 6 months post-operatively. The correction in toric group was stable with time. Nomogram and cyclotorsion compensation software upgrades and revision of surgical technique of opening of arcuates need modification. Thank you.
Thank you very much, ma'am. I think it's an established fact that toric IOLs are, of course, more predictable than
No.
LRIs.
In ASCRS and everywhere, people are presenting flax arcuate, flax arcuate. What are you saying?
No. What I'm saying
They are
is,
always presenting, even Mahipal Sachdev is presenting.
No. What I'm saying is, studies have shown that they are more practical. That's why they are more in use. And because for lower astigmatism, femto LRI and these are good. But they are unpredictable.
That's what I'm saying.
Yes.
That lower group, my study is lower group. It's not
Yes.
higher group.
Yeah.
It is 0.75 to 1.5. And when we started doing flax in 2014, we also used to do. Then patients used to come back after in 1 year, 6 months, and it was reversed.
That's true.
Then we started toric. But whenever we go to conferences, we always hear that flax arcuate is very good in lower group. Higher group, everybody is doing toric. But lower group, there is a confusion. Still there is a confusion because mostly people who are doing flax, they are always advocating flax arcuate.
Yeah, they are advocating, but
I am
we do
also
believe
doing-
that, yes.
Yes.
So, Dr. Pradeep, what's your view?
No, Vardhaman will ask a question.
Yeah.
Okay. Ma'am, two questions. Number one, which formula did you use for the toric IOL calculation? And what was the comparison between the flax arcuate versus the manual arcuate?
The same formula Barrett 2 we use,
Narrative, yeah.
and in Ontario,
Right. And what was the outcome analysis comparison between the arcuate which were done by femtosecond versus the manual?
both goes for regression.
But which was over 180 days? Which one was
Both.
more predictable? Both were equally, so
Both
yeah.
were they were non-significant. Means
Not significant,
yes,
yeah.
non-significant. I cannot say they were not significantly better to each other.
Right. So they were comparative.
Yes.
Comparative. Yeah. Sure. Okay.
And we are using flax since 2014.
Right.
So it's not that we don't have flax.
Yeah.
But initially when we started doing, we were very surprised. We were also doing flax and arcuate incisions.
Right. All right. Thank you. Thank
Thank
you
you,
so much,
ma'am.
Dr. Bhatna.
Do you have Ankita Mahapatra here? Ankita's topic is comparative study of rotational stability and visual outcomes of 4 toric IOL brands.
So good morning everyone, I'm Dr. Ankita and I'll be speaking on rotational stability of toric IOLs, a comparative study. Toric IOLs provide an effective means of correcting pre-existing corneal astigmatism at the time of cataract surgery, but its success largely depends on rotational stability, as even a small degree of rotation can significantly reduce the intended astigmatic correction. So I have included 5 commonly used torics: Clarion, EC toric, IQ toric, Johnson techniques, and Zeiss toric. So of these, as we all know, Clarion, IQ, EC, and J&J are loop haptic acrylic hydrophobic lenses, but the Zeiss is a plate and hydrophilic lens. So the aim of this study was to analyze the rotational stability of 5 different IOLs used during phacoemulsification. The objective was to compare the rotational stability and the visual outcome at 6 weeks following toric IOL implantation. This was a prospective comparative study done from March to May 2025 at Carvision Eye Hospital. a total of 500 consecutive patients, 100 in each group, were included, and the patients were divided into 5 groups according to the IOLs: C for Clarion, E for EC Toric, I for IQ, J for J&J, and Z for Zeiss. The inclusion criteria was any visually significant cataract with a presence of regular corneal astigmatism between 0.75 to 4.5 diopter, and the IOL power should be between 18 to 26 diopter. The exclusion criteria was any irregular astigmatism or keratoconus or any previous intraocular surgeries, any ocular comorbidities, any intraoperative complication where in the bag IOL placement was not possible. So all surgeries were performed by a single phacosurgeon through a 2.2 millimeter temporal clear corneal incision. Argus was used for a preoperative axis planning, and Varian was used for an intraoperative toric IOL alignment. Hydroimplantation of the IOL was done, as shown in the video. Postoperatively, we saw the patient on week 1 and week 6. We evaluated uncorrected and best corrected visual acuity, any residual refractive cylinder, and IOL axis, and rotational stability was assessed by using slit lamp photography. This is how we did it. So coming to the results, we included 100 patients in each group, but some were lost to follow-up and some were discarded due to poor pupillary dilatation, which was significantly high in torics. It is 25 to 30%. So only at the end, only we could include 329 patients. This is all the demographic data, age and gender, and preoperative astigmatism, which is not statistically significant. On comparing the degree of rotation at 1 week, group C was more stable with 9% showing rotation more than 5 degree, and group E and Z had more than 5 degree rotation in 17% of the patients. In both the group E and Z, we had 2 patients each who required re-rotation at OT because they had a rotation of more than 10 degrees. At 6 weeks, IQ and Clarion, that is group I and C, both had similar stability, with Zeiss being the least stable. At 6 weeks post-operatively, 92% of group C had an uncorrected visual acuity of 6/6, while group E performed poorly with 68%. The difference across all the groups was statistically significant. At 6 weeks follow-up, Clarion had the least rotation, and that is 3.77 mean, and Zeiss had the highest rotation, 4.58 mean. But the rotation between the groups was not statistically significant. We also compared the slit lamp axis between 6 weeks and baseline between the groups, but it was not statistically significant. As we can see from the bar graph, there is a definite reduction of astigmatism as seen by the pre- and post-operative findings, but they are not statistically significant between the groups. Coming to the discussion, there are few studies, Lee and Chang in 2018, Squat-Muller at 2024 and 2022 with Clarion and IQ, Lee et al. So all of these studies have compared different IOLs, and where mostly Clarion and IQ has performed very well, and the same stands true for our study also, where Clarion and IQ was comparatively more stable and had a better visual acuity. So coming to the conclusion, all 5 toric IOLs showed good rotational stability with more than 80% staying within 5 degree of the intended axis at both 1 and 6 weeks. No significant difference was found between the IOL groups. The Alcon, IQ and Clarion showed a better stability with maximum rotation in Zeiss toric. 2 IOLs each of EC toric and Zeiss were rotated at 7 days follow-up. Overall, all IOL groups demonstrated substantial improvement in visual acuity postoperatively, with group I and C showing the highest proportion of eyes achieving normal vision at both follow-ups, and group E had a relatively lower proportion of normal vision due to higher residual spherical power. The limitations of our study was a short follow-up and using an Argus machine, which is an Alcon machine, so maybe it has given a good reading for Alcon IOLs. Thank you. These are my references.
So how are you going to convince us that in your results you don't have influence of the companies?
Yes, that is what I said, that was our limitation, that I have included Argus machine for pre-op.
Is there any study which has actually shown that Argus gives more accurate biometry for Alcon lenses compared to the other lenses?
No, not to my knowledge.
So it is your presumption?
But I have presumed because it is of the same company.
The second thing is that have you actually segregated all these eyes also vis-a-vis their axial lens? Or
Yes, yes. We have included like the normal, we have not taken any extreme of the axial lengths.
So what were the limits for your axial length cutoff?
So it was 22 to 20 to 24.
22 to 24 millimeters.
Why do you think is the cause of more rotation in Zeiss?
I think because it is a plate haptic, so maybe it has.
But some people say that plate haptic is more stable and tend to rotate less.
Maybe because the optic and haptic, that length is less in Zeiss, maybe that is a possibility.
What is the material in Zeiss lens as
Acrylic.
compared?
All the material are same.
Zeiss is, I think, it's modified. No, it's not a pure hydrophobic.
No, it's a hydrophilic.
It's hydrophilic. That's
but
what.
acrylic.
Other lenses are hydrophobic.
Hydrophobic, yes.
So we all know that hydrophobic material have more tackiness. So IQ, these Alcon lenses, these acryol lenses, they are more tacky than as compared
Yes.
to hydrophilic.
Maybe
that
that
may
is
be
the
the reason. Yeah.
yes.
Anything else?
Thank you.
Okay.
Okay, thank you.
Thank you.
Do we have Dr. Vavish Shah here? Dr. Vavish.
Dr.
Dr.
Bhavesh?
Utkarsh Agrawal.
See, for people who are not there, they will not be considered to again present during the same session. And if somebody is presenting or submitting, it is actually mandatory that they have to be present. Anyway. So, Dr. Utkarsh?
Utkarsh? Okay. So your topic is dry eye severity following cataract surgery in diabetic versus non-diabetic patients.
Yes, can I use my laptop? It's like, okay, it is also having to present it as well. Start. Good. So, a very good morning to one and all. Today I will be presenting our prospective case control study examining dry eye disease severity following cataract surgery, specifically comparing outcome between diabetic and non-diabetic patients. This research addresses a critical gap in understanding post-operative complication in a diabetic population. So, let me set the context. Cataracts remain the leading cause of treatable blindness globally, with approximately 130 million cases in China alone, projected to exceed 240 million by 2050. While phacoemulsification has become a standard of care with excellent visual outcome, post-operative dry eye disease has significant impact on patient day-to-day life as well as visual outcome. So also, more importantly, diabetic patients already experience dry eye disease through multiple mechanisms, including corneal neuropathy, meibomian gland dysfunction, and lacrimal gland dysfunction. The question becomes, how does cataract surgery further compromise their ocular surface? So the aim of this study was to compare dry eye status in diabetic versus non-diabetic patients undergoing phacoemulsification. We designed a prospective case control study with the 140 patients, 70 diabetic and 70 non-diabetic patients, all undergoing phacoemulsification with IOL implantation. Our inclusion criteria focused on patients over 45 years with significant visual reduction due to cataract, while excluding those under 44 or with any cause of pre-existing dry eye disease such as Sjogren's syndrome or any other associated condition. And all these patients underwent uneventful phacoemulsification followed by assessment at critical time points preoperatively at 1 month and 3 months post-operatively. All three patients underwent subjective and objective tests, subjective being the ocular surface disease index scoring, and objective test being Schirmer's type 1, TBUT, and tear meniscus. So statistical analysis, our statistical analysis used IBM SPSS statistic version 23.0. Given the non-normal distribution of most variables, we employed Mann-Whitney U-test for between group comparison and Wilcoxon sign rank test for within group temporal changes with significance set at p less than 0.05. Coming on to the results, a finding reveals several important clinical insights. The primary finding was that the diabetic patient showed significantly compromised tear film stability at 3 month post-operative surgery compared to the non-diabetic at p-value being 0.02. This represents clinically meaningful difference that passes well beyond the immediate post-operative period. Despite the changes, as we can see from this graph, both non-diabetic and diabetic patient reached the baseline level at 3 months, but the progression for reaching normal baseline was slower for the diabetic population. Then also the tear meniscus tear film height played an important role, and we'll see how. We also discovered strong negative correlation between the tear film height of both diabetes duration, tear film height and diabetic duration for dry eye symptom. This correlation suggests that longer the diabetes duration may predict worse post-operative dry eye outcome. Importantly, TBUT and tear film height emerge as meaningful clinical markers that correlate well with the dry eye disease and the post-op outcome. So also, it gave us the clinical validation for the tear film tear meniscus height and TBUT emerge as clinical markers for correlating with subjective symptoms of the patient. So, however, we must acknowledge our study limitation, being a single-center study associated with systemic conditions. Single-center studies, external validity may be limited. The diabetic population had prevalence of other comorbidities like hypertension, dyslipidemia, and coronary artery disease, which could act as confounding factor. Also, that was a non-randomized design with the and socioeconomic factor might play confounding roles. So, concluding this study confirmed our hypothesis that diabetic patients show persistent compromise in tear film stability even at 3-month post-op surgery. While symptomatic improvement occur in both groups, diabetic require longer recovery periods. These findings suggest that we should implement enhanced post-operative counseling for the diabetic patients, and both in the recovery in diabetic as it was slower in diabetic patients, so they must be counseled well that post-operative, and they should be managed accordingly with better dry eye management of the for dry eye management to the patients. Thank you.
So, thank you very much. Nice presentation. Did you find any difference between patients who are having diabetes for 2 years and diabetes for 6 years?
So as we said, that duration was strongly correlated. The longer the duration for diabetes affected the post-op results, and they were more affected with the dry eye symptoms as when compared to patients with lesser duration of diabetes.
Okay.
So, what do you recommend? Like, what should clinician do when they see diabetic patients?
For diabetic patients, firstly, preoperatively, we should counsel them that postoperatively you might have these symptoms. Most often, patient will come to us with, in spite having 6/6 vision, they will complain of irritation, foreign body sensation, mostly because of this dry eye symptoms. So they must be counseled, and also they should be given well post these dry eye management, like proper lubrication, and if complaint is patient is more complaining according
That
to
we always give. No, like, do you recommend taking patient always after checking HB1AC and, you know, if it's
in the study
properly controlled and everything? Have you?
then only, yes, sir. Patients were taken only after their diabetes were well under control, but duration did affect their dry eye outcome.
Fine, thank you.
Do you have Dr. Himani here? Dr. Himani Parajpati.
Cheers.
So, topic is rosette at the core, a case of intraocular foreign body. Mike.
Hello. Yes. Good morning, everyone. So, intraocular foreign bodies occurs in 41% of open globe injuries, and intralenticular foreign bodies are rare in 5 to 10% of cases only. This result when the projectile breaches the anterior capsule and becomes trapped within the lens, sometimes sparing the posterior segment, but almost causing cataract formation. The rosette cataract is distinctive star-shaped lens opacity, usually linked to blunt trauma, but penetrating injuries when shock waves disturb the lens fibers. Metallic intraocular foreign bodies risk cirrhosis, while organic material usually causes the inflammation or endophthalmitis, making early diagnosis essential. Slit lamp examination aided by imaging such as AIOCT and UBM and CT scan confirms the diagnosis and guided surgical planning. We report a rare case of metallic interlenticular foreign body with central rosette cataract. So the case description is a 26-year male camera installation worker from Banaskantha, Gujarat, presented with pain, redness and diminution of vision in left eye 48 hours after sustaining the trauma by the iron particle. Visual acuity in affected eye was counting finger 5 meters, and slit lamp examination revealed a corneal tear, formed anterior chamber, round and reactive pupil, anterior lens capsule rupture, and rosette-shaped traumatic cataract. A metallic foreign body was visible on the posterior capsule. Fundus view was hazy with a cup disc ratio of 0.2.3 CDR, and B-scan ultrasonography and orbital X-ray confirmed the retained IFB. So we can see in the first image there is the cataract formation with the foreign body is visible in the photo. Second is also the foreign body is visible properly, and in the X-ray we can see there is a radio opacity confirming the IFB. So the management bandage contact lens was given. Topical and systemic antibiotic, corticosteroids, and cycloplegics and supportive care was given. Definitive treatment was left eye cataract extraction with intralenticular foreign body removal, and anterior vitrectomy under local anesthesia was performed, and posterior chamber PCIL was implanted in the capsular bag. Topical and systemic antibiotics postoperatively were given, and steroids and supportive treatment with regular follow-up was advised. So the post-operative day 1 photo shows that the corneal tear repair was done, and the second photo shows the slit lamp photo, picture showing the IOL, and the foreign body retrieved was also shown. On the post-operative day 7, the IOL was in bag, and the findings were on the post-operative day 2, we did the X-ray to confirm if there is any retained foreign body. It was not found. So outcomes were post-operative, it was uneventful. Orbital X-ray on the day 2 showed no residual foreign body, and best corrected visual acuity improved to 6.9. So the presence of rosette cataract in the setting of ocular trauma should raise suspicion of underlying interlenticular foreign body, even when clinical signs are subtle. This underscores the importance of thorough anterior segment evaluation and appropriate imaging to uncover hidden injuries. Early diagnosis and prompt surgical management not only restore the vision but also prevent serious complications. Recognizing these subtle clues transforms what might be considered routine trauma into the opportunity for precise and sight-saving intervention. Thank you.
So do you have a video clip of this surgery?
No, sir.
Was there any PC rupture in this case?
Yeah, so small but central, where the foreign body was stuck, it was removed and anterior vitrectomy was done manually, and IOL was placed in the bag. It was stable.
So was the posterior capsulotomy was done?
No, it
No
was
idea?
not done. No, it was not done.
It was not done?
No.
Okay.
Thank you.
Fine, thank you.
Thank you. Do we have Dr. Soumya Rai? No. I think we have the finalist from the yesterday's session. Excuse me. One second. We have the finalist from the yesterday's session. His name is not here. Yeah. It was there in that sheet which Mr. Bhupi had shown me. Dr. Sri, no, next page. Yeah? Yes, sure. So Dr. Pranav Prabhu, yes. So today is basically both the semi-finals for Cataract 2 and overall a final also. So Dr. Pranav has yesterday come as the finalist from the Cataract 1 session, and the winner from the Cataract 2 and Dr. Pranav's marks will be compared to give the best paper. So over to Dr. Pranav. He is going to present his paper on precision and simplicity, role of OCCI in correcting corneal astigmatism in phacoemulsification. Over to you.
Thank you, sir. Good morning to all the judges and the delegates here. So today I'll be talking on role of opposite clear corneal incision in correcting pre-existing corneal astigmatism. So we know the modern day cataract surgery is a refractive surgery, and our patients are also very demanding. So we have always often encountered patients who are unhappy even after the cataract surgery, and one of those reasons could be a pre-existing corneal astigmatism which we have not corrected. Now there are various modalities to treat it, but here we are talking on one of the feature, that is the OCCI, which is a cost-effective management for astigmatism management compared to more expensive options like toric IOLs, especially in a resource-limited settings. So when we do an opposite clear corneal incision, there's an enhancement and additive flattening effect of 2 corneal incision compared to single incision. And with this, we'll want to evaluate the efficacy so that this can be a standardized approach for all the patients who cannot afford toric lenses. So aim remains the same, to evaluate the efficacy of adding an opposite clear corneal incision, and we assessed how much was the reduction in the pre-existing corneal astigmatism and the visual acuity. So patients undergo cataract surgery monofocal IOL for a period of 1 year. It was a prospective cohort study with 30 eyes of 30 patients. So these were the inclusion and exclusion criteria, inclusion being mainly a senile cataract and patients undergoing monofocal non-toric IOL. So preoperative parameters which were measured were vision, refraction, slit lamp, dilated fundus exam, intraocular pressure using NCT, and both keratometry and biometry was measured using the IOL Master 700. And Barrett's Universal 2 formula was used for IOL calculation. So the 30 patients were divided into 3 groups of 1 to 1.5 diopters, 1.6 to 2 diopters, and 2.1 to 3 diopters. And precise marking of the steep axis of the cornea was done according to the K value on slit lamp, using a sterile marker under topical anesthesia with the patient in the upright position to correct for the cyclotorsion. So then the patients will undergo a standard phacoemulsification under local or topical anesthesia. The first is the main incision, which is made at the steepest meridian, and then the planned monofocal IOL is implanted in the bag and the AC is maintained by a dispersive OVD, then followed by the opposite clear corneal incision on the same axis 180 degrees away, and this OCCI will not be hydrated nor sutured. Post-operative follow-up at 1 week and 6 weeks, and statistical analysis was done using student t-test and chi-square test. So the baseline parameters were statistically not significant. And we come to the result, you can see in each group there was reduction from 1.25 to 0.67 in 1 to 1.5, from 1.72 to 1, and 2.42 to 1.47, all the 3 groups. So when we look at the mean reduction, it was 0.5 in less than 1.5, 0.72 diopters in 1.6 to 2 diopters, and almost 0.95 diopters, with the overall reduction being 0.6 diopters. So uncorrected astigmatism is a very major cause for suboptimal uncorrected visual acuity after cataract surgery. We know that we have a lot of options to correct it, like toric IOLs, which are actually very good results but very expensive. We have limbal relaxant incisions, again heals very quickly with minimal astigmatism correction. And excimer laser ablation too, they're pretty expensive with again flap related complications. So here we emphasize on opposite clear corneal incision, especially in a developing nation like India, where it is a better alternative in providing good visual acuity in patients who cannot afford all the other options. So this is a very self-sealing incision. There's no added risk, it requires no extra surgical equipment, and it's very effective in reducing astigmatism. Multiple studies are done which are shown to reduce astigmatism on an average of 1 to 2 diopters, with the published results ranging from 0.85 to 2.25 diopters. So in our study, the mean reduction was 0.6 diopters overall at 6 weeks post-operative, and the reduction was consistent across all groups, I mean more than 0.5 diopters. So limitations, however, were small sample size and short follow-up duration. So to conclude, this study could establish OCCI as a simple, cost-effective, and accessible surgical technique for correcting pre-existing corneal astigmatism during cataract surgery, thereby improving visual outcomes and reducing spectacle independence, emphasizing on resource-limited settings. Thank you so much.
So in your study, how much correction you have found?
So we have divided into 3 groups, and each group we have from the least reduction was 0.5 diopters all the way till 0.9 diopters. So we can safe to say that it is 0.5 to 1 diopters reduction can be achieved through OCCI. And what we want to emphasize is, even though patient may have more diopters of astigmatism, now we know in India it's a more of rural population which we are operating on. So some reduction is better than no reduction for those patients, because we are still implanting monofocal IOLs in those patients. So
True.
We just want to emphasize on that, sir, with this study.
What is the setup where you work?
I work in, I'm a junior resident at Ramaya Medical College, sir, Bangalore.
Okay, okay, fine. So, like, what do? You just leave these incisions open, right? 2.8. You don't hydrate them?
No, we don't hydrate, we don't suture it, sir.
What about leakage? Like, have you checked?
With all the studies we have done, it has been shown to be there's no post-operative complication, no wound leakage. So we have not experienced any complications yet. There were complications with a larger incision, 3.2 mm in the previous studies. So we have tried to find a sweet spot of 2.8 mm incision, because even going for a lesser incision, 2.2 mm, there have been studies, but that has been shown to have a lesser astigmatism inducing effect. So with all the literature review, we found 2.8 mm was the best to give the incision compared to 3.2 or 2.2.
So any relation with the length of the tunnel, corneal tunnel? More
Definitely, sir. The length as well as the location, whether it is more on the center of the cornea, so that also makes a difference. But here we wanted to standardize it at 2.8. So there can be further studies where right now we don't have any nomograms for OCCI. We have nomograms for LRIs. So probably with further studies with a much larger trial, we can have a nomogram where we can have this much length incision for this much correction of astigmatism. So even though now we are not achieving complete e-metropization, but probably with a better and a larger study, we can completely reduce the astigmatism.
Have you compared with the rule versus against the rule astigmatism and its effect?
We haven't particularly compared it, sir. So we have sat on whichever is the steepest meridian axis. So that was where our main incision was.
I think that is one of the reasons that in the studies that you have shown, there is a vast, basically, range between 0.8 to almost going to 2 diopters.
Yeah,
Because if you go with the rule, the astigmatism correction is far, far more.
Yes, sir.
Yeah, sure. Thank you very much. Thanks.
Thank you, sir.
So
Yeah, paired.
We believe it might change. When we went through the...
That's my question.
Okay.
If we do the hydration, because that will put the eye on a safer side. Because endophthalmitis, we take disinfectant, then directly the astigmatism.
In my thinking, hydration is a temporary thing and it should
yeah.
not cause any change in the result.
I believe that, see, I agree that for rural setting where, they can't afford anything, it's okay. Otherwise, in today's era, I believe
sir,
that
we
if
agree
you
with-
have IELMaster 700 and, I believe before IELMaster 700, you can have 900 toric lenses now.
Yes, definitely, sir.
Yeah,
But
so just for rural setting where patient can't afford, you achieve some reduction. That's the only point there. Thank you very much.
thank you, sir.
Yeah.
Thank you. So I think all the competitive papers have been presented. Now we invite Dr. Shritu Shell for presenting the keynote address on determining ICL sizing, comparing white to white measurements using different devices. Do we have Dr. Shritu here? Not really, okay. All right, so thank you very much. We come to the end of this session, and please continue to be present for the next session as well. This was a competitive session, so I think all the marks will be tabulated, and the scientific committee office will reach out to the participants about their results. Thank you very much. Thank you. Yeah, we
Yeah,
can
yeah,
have. We
please
can have a
come.
group photo of all the
Yes.
presenters, please. Can you come in front? Yeah.
Yes, we will go forward.
Come on.